I don't know.
Welcome, everybody, to our November Grand Rounds. This morning, I have one announcement, and that is to introduce Kristen Burns, if she's joining us this morning. And Kristen has joined Dr. Wong as a PA on the hand service. Welcome, Kristen. This morning, our topic is going to be proximal junctional kyphosis after adult deformity surgery. And our speakers are going to be Mario Taylor, an R4, and Haitao Zhou, an assistant professor in the Department of Orthopaedics and Sports Medicine. And everybody knows that Dr. Zhou practices spine surgery at Harborview. And since I am sure that everybody went to bed early, is well rested, and has absolutely nothing else on their minds this morning, Doctors Taylor and Zhou are going to have our undivided attention. So Dr. Taylor.
Good morning, everyone. Screen. All right. Hoping I'm showing my presentation correctly. Good morning, team. My name is Mario Taylor. I'm currently an R4 here at the Department of Orthopaedics, and this morning I'll be giving my presentation on adult spinal deformity and the importance of global sagittal balance, followed by a presentation mainly on proximal junctional kyphosis by Dr. Zhou. Start off, I have no disclosures. In this presentation, I'll be giving a brief introduction, going over pathoanatomy of adult spinal deformity, as well as patient presentation, some key imaging, treatment, as well as outcomes. So to start off, introduction, adult spinal deformity is defined as spinal malalignment that occurs in either the coronal, sagittal, or axial planes, or multiple planes. And this can be due to more or less two different reasons. First of which being residual idiopathic scoliosis from childhood that later needs treatment in adulthood, or degenerative scoliosis that occurs with changes that occur in the thoracolumbar spine. So briefly, pathoanatomy. Some of the causes that can contribute to degenerative scoliosis, degenerative disc disease, that can lead to progressive wear of the disc over time, leading to loss of lordosis within the lumbar spine, or excessive kyphosis in the thoracic spine. Additionally, in the coronal plane, you can get asymmetric wear that leads to angulation of the vertebral bodies in the coronal plane. Degenerative changes of the facet joints, osteoporosis, and fragility fractures, especially in the thoracic spine, can lead to excessive kyphosis. Post-traumatic changes, iatrogenic, such as flat back syndrome and proximal junctional kyphosis above previous fusion sites. Patient presentation. The most common symptom these patients will be presenting with is lower back pain. Additionally, radiculopathy and leg pain. Generally, this is found on the concavity of the deformity, though patients definitely can present with symptoms on the convexity of the deformity, particularly when the deformity progresses in severity. Neurogenic claudication is another type of another way patients can present, though this is somewhat different than patients with general lumbar stenosis, and that flexion generally does not relieve symptoms for these patients. Weakness and numbness, increased energy expenditure, as well as difficulty obtaining horizontal gaze. This is particularly true with severe types of deformity. And just touching briefly on this image of the patient on the right, as you can see, she is has her knees bent. She's kind of has her center of gravity forward away from her center of femoral heads. And this position overall increases the energy expenditure and difficulty with horizontal gaze. And then just jumping back to this previous slide that I have here, it mentions some of the compensatory mechanisms that patients will perform in order to try and recenter their center of gravity. Overall, these changes on the right lead to a progressive migration of the center of gravity from over the femoral heads to anterior to the femoral heads. And some of the ways that patients can try and correct this or compensate this is through excessive cervical lordosis, hip extension, knee flexion, as well as pelvic retroversion, which results in an increase in their pelvic tilt, which I'll touch on in a bit as well. Some key imaging. Most important thing is going to be the fact that we need to identify deformity in all three planes. So using standing full-length plane films, CT scans, as well as MRI. Obviously, MRI is great for identifying any areas of stenosis. CT scan gives great delineation of bone morphology. And then the standing plane films are generally used for assessing overall sagittal or coronal plane balance. Some of the key things to note here: your sagittal vertical axis, your pelvic incidence, and your T1 spinal pelvic inclination. So once again, some of the key parameters. So this first one, sagittal vertical axis. This is defined as the distance between C7 plumb line and a vertical line that passes through the posterior edge of the superior sacral end plate. This ideally should be less than 2.5 centimeters, though we consider this to be pathologic once it's greater than anywhere from 4 to 5 centimeters. So once again, you can see that the center of gravity is getting shifted forward anterior to the central femoral head when you have a positive sagittal balance. Pelvic incidence. Pelvic incidence, as many of you know, is defined by the sum of pelvic tilt and sacral slope. Generally, pelvic incidence is thought of as a fixed parameter that stays the same, while pelvic tilt and sacral slope can change with patient positioning or compensations. So as I had previously mentioned regarding patients increasing their pelvic tilt to compensate for sagittal imbalance, that corresponds to rotating this their pelvis into retroversion, so kind of shifting this backwards. And that leads to an increase in your pelvic tilt with a subsequent decrease in your sacral slope, resulting in a pelvic incidence that essentially stays the same. T1 spinal pelvic inclination. This is another kind of way to evaluate patients with sagittal imbalance. And when compared to SVA, it's an angular measurement, while SVA is a linear measurement. Then I have two studies that I'd like to go through that show kind of the importance of sagittal balance. So this first one that I have is published by Dr. Glassman in 2005. The goal of the study was to define parameters that might affect clinical impact. They looked at about 352 patients with adult spinal deformity and positive sagittal balance, with their main variables being radiograph parameters and health status measures as measured by SRS, SF12, and ODI questionnaires. The average age of these patients was 54, with a mean SVA of 5.7 centimeters. They're able to show a high degree of correlation between positive sagittal balance and adverse health outcomes, once again as indicated by ODI, portions of the SF12 and the SRS questionnaires. Additionally, they were to show evidence of increased pain and decreased function as the amount of positive imbalance increases. This next study I have was published in 2009 out of NYU. The main goal of their study, study was to determine the relationship between spinal pelvic parameters and patient outcomes. This was a prospective study that included about 125 patients with adult spinal deformity. They were able to show a correlation between increased pelvic tilt, positive SVA, and spinal pelvic inclination, with better results on the SF12 SRS and ODI questionnaires, while there's no correlation found between coronal plane parameters. Some treatment options. Non-operative treatments are obviously the place to start for all patients. So PO medications, physical therapy, epidural steroid injections are all things that these patients may benefit from. Particularly in patients with severe deformity, these treatment options can have limited results. Operative treatment indications: coronal plane deformity greater than 50 degrees, severe leg pain or back pain resistant to non-operative treatment. Cardiopulmonary decline doesn't occur until curves progress to in coronal plane curves progress in severity to greater than 60 or greater than 90 degrees. Once it greater than 90 degrees, you have an effect on mortality as well. Common treatment options include posterior instrumentation fusion, as well as combined interbody fusion with posterior instrumentation fusion as well. In addition to that, the way that we can correct deformities, particularly in the coronal and sagittal planes, are a number of different types of osteotomies. The first of which being the Smith-Peterson osteotomy, the Ponte osteotomy, pedicle subtraction osteotomy, and the vertebral column resection. Here are just some examples of all three. A representing Ponte osteotomies and or Smith-Peterson osteotomies, B and C being pedicle subtraction and vertebral column resection. So this first Ponte osteotomy is an osteotomy, posteriorly based osteotomy that involves resection of some of the posterior elements. It involves shortening of the posterior column and not necessarily lengthening of the anterior column, which differentiates it from Smith-Peterson osteotomy, which I believe is generally thought as shortening of the posterior column in addition to lengthening of the anterior column. Smith-Peterson osteotomy, I believe, was initially described for the ankylosing spine, while Ponte osteotomies were initially used for patients with Scheuermann's kyphosis. So goals of treatment: you want to obtain appropriate decompression for patients with neurologic symptoms, obtain stabilization and solid fusion, as well as restore some of those radiographic parameters that I mentioned previously, such as the SVA, your T1 spinal pelvic tilt, and additionally, another parameter being your pelvic incidence and lumbar lordosis mismatch being around 10. And once again, patients that were able to post-operatively have these values were more likely to have positive outcomes on their healthcare quality of life questionnaires. Complications are unfortunately a very real complication associated with adult spinal deformity surgeries. Overall, anywhere from 20 to 30%, with major complications being around 10%. Some of those complications being non-union dural tear, infection, neurologic deficits that can occur and do occur more frequently in patients that undergo osteotomy, such as the pedicle subtraction osteotomy. Proximal junctional kyphosis, once again, another complication. So this next study I have is kind of highlights some of the benefit that patients with adult spinal deformity can achieve after undergoing surgery. So this study was published in 2015. It was a multi-center study that included 421 patients split into operative and non-operative treatment groups in patients with adult spinal deformity. The main variables they measured they measured their variables at initial presentation and at 2-year follow-up. The data showed that patients treated operatively were more likely to show clinical improvement in the form of numerical rating scale of their back and leg pain, as well as their ODI and SF36 questionnaires, compared to patients that did not undergo surgery. Patients that were treated non-operatively were more likely to have back and leg pain that remained the same or worsened at the 2-year data point. So it's clear evidence that patients that do undergo these surgeries for these for adult spinal deformity, despite the complications, frequently do well. And then a quick summary: adult spinal deformity causes significant disability, and particularly in patients that have gone on to severe deformity. Restoring sagittal balance is found to be more important than coronal plane balance for reducing disability and better outcomes. Patients with adult spinal deformity frequently do well after surgery, barring complications. Even those that do have complications generally have fairly well outcomes. As with all surgeries, careful patient selection and optimization is key for success. So my references, that'll be it for me. Thank you.
Hello, hi, good morning. My name is Haitao Zhou. I'm currently practicing at the Harborville Medical Center. My topic for today is proximal junctional kyphosis in adult spinal deformity patients. Thank you, Mario, for a good overview of the adult spinal deformity treatment. So the current treatment of adult spinal deformity actually started in the 1950s. Harrington rod was first introduced in 1953. It was like a 2-point of fixation on the proximal and the distal end of the construct. Pretty much like all treatment options, Harrington rod came with complications as well. We can see on the right screen, the patient doesn't have the lordosis.
Hi, Tal. Are you sharing your screen? I don't know if I'm the only one. I can't see it.
You have to share your screen, Dr. Zhou.
Oh.
No, because I can hear the sound.
All right, can everybody see my screen now?
Yes.
Sorry about that. So this is Harrington rod introduced in the 1950s. As you can see on the right side, the patient do not have lumbar lordosis, which is causing flat back syndrome and cause a lot of issues down the road. From there, we developed Lukey sublaminar wire. We changed from 2-point of fixation to multiple point of fixation, and then introduced the Galveston rod, which you can bend the rod and give the patient the curvature that they need for their spine. And then we developed the pedicle screw system, which introduced in the 1960s. With the pedicle screw system is actually quite powerful, not only for deformity, but also for trauma patients. Now we understand more and more about sagittal balance, and we understand about pelvic incidence, lumbar lordosis, pelvic tilt, sacral slope, all that, and we use that for patients to try to get a better outcome. Compared to several decades ago, we are doing a whole lot more. Of course, the pedicle screw system comes with complications as well. Like the patient I showed earlier, that patient had surgery in 2 days, total of 18 hours. Of course, the infection rate is much higher for patients for underwent surgery for that long, and that patient had a fusion from T4 all the way down to the pelvis, was total of 14 levels. You know, the non-union rate is going to be much higher than 1 level or 2 level lumbar fusion. And hardware failure comes hand in hand with pseudoarthrosis, and then we have this pretty unique complication for adult spinal deformity patients, which is proximal junctional kyphosis. This is a patient in her 60s, had a T10-2 pelvis in February of 2016, and developed PJK at T10 level pretty quickly after surgery. Then in October of the same year, 8 months later, she had extension to T4. 3 weeks post-op visit in clinic, we noticed the PJK again at T4. She was, we planned to do surgery for her. She left the clinic, went home, and fell the same day, and had a spinal cord injury, Asia B. She returned to Harborville, and we performed emergent extension and decompression. Now she's fused from C2 all the way down to pelvis. Proximal junctional kyphosis first was noticed in idiopathic scoliosis patients with Harrington rod. The first publication came out in 1999. The definition of PJK back then was more than 5 degrees of kyphosis from T2 to proximal fusion level than the normal range. That is not the definition we're using anymore. Then the proximal junctional kyphosis in adult spinal deformity patients, the first publication came out 2005. In that paper, the incidence was about 26%. Their conclusion was PJK did not change the SVA, did not change the overall alignment, or did not change the clinical outcome. As we can tell, for some patients, that's really not the case. To make a diagnosis of PJK, you have to have 2 criteria. Number 1, proximal junctional sagittal cup angle needs to be at least 10 degrees. Number 2, post-operative proximal junctional sagittal cup angle should be at least 10 degrees greater than the preoperative one. This is a patient underwent T10-2 pelvis for his lumbar pathology. Immediate post-op, we noticed, we measured from the upper instrument vertebrae +2, that is 2 levels above the top instrument level, to the upper instrument level, which was 14 degrees of kyphosis. At 6 months follow-up, the same measurement, from the UIV +2 to UIV changed from 14 degrees to 25 degrees. So he was diagnosed with proximal junctional kyphosis. This is another patient in her late 60s, had index procedure in 2014. She did really well for 3 years. Early 2017, she was still asymptomatic. This is the X-ray, 2 X-rays on the left. She did not have PJK. Then November of the same year, she started having pain. We got new X-ray, showed more kyphosis over 20 degrees. So for her, the PJK came in quite late. Based on literature, the incidence of PJK is about 17% to 61%. It varies from different type of deformity, levels of fusion, and the follow-up time. Like we can tell, if the patient had non-treated idiopathic scoliosis and then got treated when they are over 18, they still belong to adult spinal deformity, but normally they have surgery early on in their life. What we are treating most at Harborville is the patients developed lumbar pathology, developed degenerative scoliosis and the sagittal imbalance. So they are quite different category of patients, but they are all called adult spinal deformity patients. Clinically, the patient's symptoms can vary dramatically. Some patients can be totally asymptomatic. They have no pain, no issue, and some patients may have pain at the junctional level. Some patients may complain of loss of sagittal balance. They were able to obtain horizontal gaze, but since this pain started, they cannot get the horizontal gaze anymore. And on the most severe side is the patient may have neurological deficit or spinal cord injury. Then Yagi proposed proximal junctional failure. This paper was published in 2014. In their paper, they had 23 cases called proximal junctional failure. The definition was PJK that require revision surgery. They call that PJF. Among those 23 patients, 16 had severe pain, 6 patients had the neurological deficit, and only 1 patient had sagittal imbalance. Among all the 23 patients had the surgery, 12 out of the 23 had major complications, and 11 out of the 12 had another PJK or PJF, and the 9 patients required further surgery. That's almost 40%. Proximal junctional failure, in current days, the definition is a little bit different. The patient, to be called PJF, they have to have at least one of the 5 entities, which is fracture of the UIV or UIV plus 1, or they have hardware failure pulling out the pedicle screws, or they have adjacent vertebrae subluxation, which is also called spondylolisthesis, and the neurological deficit related to PJK or extension surgery within 6 months. In the original paper in 2014, they also presented a classification system, which is type 1 purely soft tissue failure, type 2 is bony fracture, type 3 is hardware failure, and the grade A, grade B, and the grade C based on the degree of kyphosis and whether the patient have spondylolisthesis. They put N or S to the classification. So what is causing PJK? If we have to use one word, that would be multifactorial. There's not a single one factor can cause PJK. Normally on the patients over 55, they have osteopenia or osteoporosis. They're at the higher risk for PJK. And during surgery, if they had disruption of the posterior soft tissue, like inter and the supraspinous ligaments, they're at a higher risk for PJK. And there are a lot of research done to study which level of fusion will prevent or decrease the possibility of proximal junctional kyphosis. Normally, what we do at Harborville is we go up to T10. The theory is we connect our lumbar construct to the thoracic cage, which in theory can reduce the proximal junctional kyphosis. There are literature saying, you know, T10 is not the perfect level. You may need to at least go up to T9, or some papers say maybe L1 is better. For that question, still needs more study and research. And then there are tons of papers showing if you extend the fusion to S1, then the PJK risk increased at least about 50%. But unfortunately for our patients, if they come in with lumbar degenerative scoliosis, sagittal imbalance, most of the patients need to have fusion go down to S1. And then this is not a modifiable risk factor to us. And then the last one is the preoperative imbalance. You know, the patient, if they have large sagittal correction over 30 degrees, they belong to the high risk group for PJK, but if that's the main goal for index procedure, I do not see any, we can really change this part. Then this meta-analysis paper published in 2016 pretty much showed similar results. Risk factors are age over 55, fusion to S1, hyperkyphotic in the thoracic spine, low BMD, and the SVA difference from pre-op to post-op was more than 5 centimeters. So because we really cannot do much to prevent it, and is there anything more we can do during the surgery to try to reduce the PJK and the PJF. Then this paper came out 2018, trying to look at the preventive vertebroplasty to the upper instrument vertebrae and the UIV +1. See whether that can reduce PJK. Their conclusion was very clear. This vertebroplasty did not do much to prevent PJK, but I have a little different opinion. By looking at their numbers, their vertebroplasty group had only one revision, which was 3.6%, versus the control group, they had 14% revision surgery. I mean, on statistics, there is no difference, but I think with more patient, potentially there could be a difference. But also, we have to keep in mind when we put the bone cement in the vertebral body, around the screw or without screw, it could be really difficult for revision surgery down the road. Then this paper published in 2018 showing ligament augmentation to prevent PJK. Their conclusion was the ligament augmentation can help, but their study group had only average 12 months of follow-up. Is there a possibility that ligament augmentation can only delay the PJK from happening, and the 12 months may not be long enough to catch the true incidence of PJK in that patient group? Since we really don't have a good way to prevent it, whenever PJK and the PJF happens, we have to deal with it, we have to treat. In my understanding, if they are completely asymptomatic without spondylolisthesis, I really don't want to do any more surgery. I watch the patient closely. I bring the patient back every 3 months, every 6 months, every year, getting new x-rays and asking their sagittal balance, their symptoms, and really try not to do more surgery because previous studies showed 50% of those patients end up with another PJK after the extension of previous one. Then if the patient, they have sagittal imbalance and then correct deformity surgery like a pedicle subtraction, osteotomy is indicated, and most of the patients need the extension of fixation to a higher level. So here I have 2 cases. This is a 55-year-old male had the previous surgery for T10 to pelvis, and he developed a PJK at about 6 months.
Hey, Haitao?
Yes.
It might just be me, but you're fading in and out a little bit with your voice, so just make sure you're close to your microphone.
Okay.
Thanks.
So this is a 55-year-old male had the T10 to pelvis fusion decompression. At 6 months follow-up, he complained 2 symptoms. Number 1, severe pain in the mid-back where the previous surgery stopped. Number 2, he lost sagittal balance. He was compensated before. Now he cannot get good horizontal gaze. He had to try really hard, work really hard to bring his upper body back. By looking at the CT in the middle, we can see the hardware failure on the top, which is T10, and also from the index procedure, I used the BMP, try to get better fusion that caused osteolysis between L5 and S1. That's quite significant. Also, the patient had hardware failure. You can see on the right imaging at S1 level, also the connection between the rod and the iliac screws. So this patient had about 25 degrees of kyphosis, actual kyphosis from the PJK. We got consent to do a PSO, and during the second procedure, he lost about 2 liters of blood during the exposure. So the anesthesia team stopped us from doing the PSO. So I just connected 5 levels above, stop at T6, and I tightened the rod and put in the bone graft. I was really hoping that when he wakes up from anesthesia, will tell me, I feel great, I don't really want to have the PSO. But that's not the case. He complained still sagittal imbalance. He wanted the PSO done. So we did the PSO at the T10 level. The reason I chose T10 was the hardware failure at T10. You can see the large screw track. Basically, I exposed the pedicles and take down the pedicle and make a wedge cut and close down the posterior part of the spine and correct the deformity. The patient correct about 15 degrees. And on the right side, you can see the sagittal balance improved. The patient is quite happy at this point. Of course, we have to revise the bottom of the construct later on. That's another story. So this is the sagittal SVA. At the initial post-op was about 87 millimeters positive. After PJK was about 91, but he was probably compensating. And even before the PJK happened, he was probably just barely compensated overall. And the PJK really threw him off that he required deformity surgery like PSO. And then after only the extension of fusion without PSO, his SVA was still positive 91 after the PSO was positive 58. And second case is a 70-year-old female. She had T11 to S1 fusion 2013, did well for three years. Until 2017. And as you can tell, the SVA was about 100 millimeters positive before PJK happened and was about 117 millimeters after PJK. So she had twofold of symptoms, mid-back pain and the sagittal imbalance. She did well for 3 years without any PJK. That was pretty amazing how late her PJK happened. Then with PJK, she got extra 20-25 degrees of kyphosis at UIV plus 2 to UIV. Overall, her pelvic incidence and the lumbar lordosis are pretty close. So this patient I chose to do the PSO at the level above because that's the fracture level. She really didn't have a loosened pedicle screws from T11 all the way down to S1. So I exposed the pedicle at T10 level. And because of the thoracic spine, I can sacrifice both nerve roots at T11, make the PSO much easier. You really cannot do that in the lumbar spine level, but it's also because of its thoracic spine, the spinal cord level. You really cannot shorten the cord too much. So for this patient and the patient before this one, I was aiming at about somewhere between 10 to 15 degrees of correction. The fluoro shots on the right showed that the PSO was closed and the deformity surgery was like finished. Then this is the pelvic parameter. I don't know why I have twice. So this is the CT showed the PSO was closed at the T10 level, and the post-op kyphosis was about 11 degrees from the 2 levels above to the UIV comparing to right after index procedure. And her SVA was corrected from 117 to 60. And on the right is the X-ray from 1 year from the PSO. She healed the PSO site and she's asymptomatic and she doesn't have another PJK yet. So in summary, PJK-PJF is a relatively common complication after adult spinal deformity surgeries. Clinically, the symptoms can vary from asymptomatic to spinal cord injury. It's a very wide range. The cause of the PJK is multifactorial. Extensional fusion is indicated for severe pain. If they have sagittal imbalance, osteotomy deformity correction is indicated as well. Revision surgery for PJK and PJF, they have high complication rate. Thank you. This is all I have.
Thank you, Dr. Zhou and Dr. Taylor. That was excellent. And that's a beautiful picture, Dr. Zhou. Before we have questions, maybe you can tell us where that was taken, if it's yours. And everybody is welcome to just speak up and ask a question, or you can use the chat function and direct it to myself or Aaron. So Haitao, was that your photo?
No, that wasn't. This comes with the Windows.
Okay.
I have a question. Thanks, Haitao and Mario. This is Jen Bauer. Haitao, have you guys made any transition towards or thought towards using a personalized pre-contoured rod based off of the patient's pelvic incidence? There's been some popularity of that with the adult population to try to give them the correct exact contour to hopefully prevent PJK?
We do not have that.
Do you think that it helps, or do you think that it's more related to the quality of bone, your dissection technique, or something else?
I think it's mainly related to the quality of the bone and also the soft tissue. And basically, because of the long fusion, we changed the whole biomechanics of the spine, right? The spine lost all the cushion from the discs. Every step patient walk put stress on the top level. I think that's the cause of the PJK. I try not to use persuader for my top level or top two levels. When I connect the rods, I try to bend the rod, make them just go in directly. I don't know that really helps.
Haitao.
Yes.
I'm sorry, I thought you were done. Your voice faded out. I noticed that you didn't mention much, or at least I didn't notice it, about some of the techniques that have been used to try and prevent PJK in terms of the so-called soft landings and actually just quickly in reference to Jen's comment, I would agree that I don't think the problem is not getting the right alignment. In fact, I think in the adult world, we worry that maybe we should leave people a little bit more kyphotic.
Sure.
Because I think when we correct people perfectly, they want to drift back to a little bit of kyphosis. But I mean, I always think that that's an interesting concept, but I don't think it would help the PJK issue that much. But anyways, getting back to my question, in terms of soft landings, using rods that have either slightly lower diameters or more flexibility at the top, or using hooks at the very top, or on the other side of the coin, using things like vertebral augmentation techniques at adjacent segments. Do you have any comments on some of those strategies to try to minimize the risk? Someone, either you or Mario, brought up the tension band, the use of a tension band above, and I have to admit I indeed more of those than I'd put in. But anyways, just in general, just strategies that we can potentially use and whether you think they're successful.
So I mentioned a paper investigated the vertebroplasty. Seems like their conclusion was that didn't work, but I think maybe that potentially can help. We don't really know. I did not mention the soft landing, like the taper rod, or I mean, there's literature saying hooks. Using hooks doesn't really help. I did not quote any paper from that I mean, kind of I did with one. I didn't specifically mention that. Doesn't feel like we really have a good solution to prevent PJK from happening.
Hey, hi, Tao. It's Howard. I was going to ask something similar to what Carlo asked you, whether there was such a thing as either tapered rods or rods with some sort of gradient of stiffness as you moved towards the end of the fusion. I think that's what Carlo asked you. And so my follow-up question is, once somebody is fused, can the stiffness of the rods actually affect motion to any appreciable degree at those levels? Because if the spine is stiff once it's fused, it really wouldn't matter, you know, what the stiffness of the implant was.
Yeah, I think that's pretty much true. Once the bone fused, the hardware don't really do much work.
Yeah.
Then the patient still have the stress like concentrated on the proximal junctional level.
Yeah. So no real way to make even the fusion less robust, less stiff. Once it's fused, it's fused.
Right. You know, on the other side, if we don't have fused, we're looking at pseudoarthrosis, hardware failure revision surgery. It's a really difficult situation.
Yeah. And do you have to follow these patients for life? Does the risk ever subside with time, or is it linear with years? You know, does it increase linearly or stay stable, the risk with years after surgery?
I think most patients develop PJK quite quickly after their index procedure. The second case I presented was sent by Dr. Wagner when she had surgery done, not by me or at Harborville, and she developed PJK 3 years later. That was quite uncommon.
Does anybody else have any questions for either Dr. Taylor or Dr. Zhou?
Quick question for Mario. When you looked at your, when you were looking at Ponte's versus, you're making a distinction between Ponte's versus Smith-Peak osteotomies, can you think of situations where you would do one or the other, or to you, are they, for practical purposes, basically the same?
So I think based on what I've read, the key, I guess the key difference between the two is whether or not there's lengthening of the anterior column as well. So I think from if I'm understanding things correctly, the patients that have either ankylosing spines or any other reason that they would have a fused anterior column would be a reason to want to use the Smith-Peterson osteotomy, while the Ponte osteotomy, I think, is more frequently used when there's intact anterior or no changes to the anterior column and there's no plan to actually lengthen it.
What do you think, Haitao?
I mean, to me, they are about the same.
Yeah, I mean, I struggle with I think that there are fundamental differences between the two, but I struggle with the idea of, I kind of feel like when you're doing that osteotomy, you're essentially doing something that's you're doing the primary element of either one, and I don't know that, you know, people argue about the distinction between the two, but for practical purposes, I don't know that it really matters.
Yeah, I did have difficulty finding some true, differences in the literature between the two, aside from how they were initially described.
I'd agree.
Are there any other questions?
Haitao, do you have an angulation that you sort of use as a definitive, like you defined what the literature, or you mentioned what the literature defines as PJK, but do you have a number that you absolutely operate on versus one that you don't absolutely operate on? or you absolutely don't operate on, I should say?
I tend to look at their symptoms. If they are asymptomatic, no spondylolisthesis, I tend not to operate on them. Because I had a patient, I did the PSO, she got another PJK, but she is still asymptomatic. I mean, she's already fused to T4 now. If I go up, I'm going up to C2. I mean, that patient, I'm still following up and trying not to do surgery. I don't think any number really make sense because patients they have really different tolerance of symptoms and the pain, all that. I don't know. Do you have a number in your mind you do surgery?
No, I think these patients are complex, and I think that's kind of what I was getting at. I think you need to, I would agree with you, you need to treat them on an as needed basis. There's someone I'm following right now who I just came in, who has a pretty dramatic angulation, but she's completely asymptomatic. So I actually was trying to talk her into surgery because of the fact that it's so severe, but we're kind of waiting it out. But just to give you an idea that there are a lot of components other than just looking at, the deformity.
Yeah, I kind of agree with that because once they have one PJK, you do another surgery, they got another one. It's really difficult to explain to patients.
Okay, well, thank you, Dr. Taylor and Dr. Zhou. That was excellent. Thank you for presenting it in a way. I think it's a very complicated topic, and you presented it in a way that I think was stimulating for both the spine surgeons and the non-spine surgeons. So great job. Everybody have a nice day. Try not to be too distracted, and have a great Thanksgiving, and see everybody in December. Thank you.